Well, hello everybody, and welcome to CE Elevated, a CSU Vet CE webinar series. I'm your host, Dr. Ross Palmer from Colorado State University, and I'd like to thank you for joining us on behalf of CSU Vet CE here at the Translational Medicine Institute. We've named this webinar series CE Elevated. That's symbolic of our Colorado mountainous terrain, as well as our mission to provide you with an elevated CE experience in all that we do. We believe there's great power in the collision between inspired learners, engaged educators, and meaningful experiences. Tonight, we're sincerely thankful for the support of Arthrex Vet Systems, who has made this webinar episode possible. Tonight, we do have a special treat for you. We are joined by two good friends and very talented equine surgeon, Dr. Elevated-Goodrich and Dr. Brad Nelson. Dr. Goodrich is the director of the Orthopedic Research Center at Colorado State University's C. Wayne McElraith Translational Medicine Institute, and an equine surgeon specializing in orthopedic surgery and lameness with a focus on musculoskeletal injuries and trauma. She holds the Barbara Cox University Chair in Orthopedics and is an ACVS Founding Fellow in Minimally Invasive Surgery, that in large animal orthopedics. She began at CSU in 2005 as an assistant professor of equine surgery and is currently a full professor of surgery and a principal investigator in the Orthopedic Research Center. She's a translational scientist whose research focuses on regenerative medicine, gene therapies, and biologics to improve both joint and bone repair in both animals and people. She's an active faculty member for the AO Vet and on the board of directors for the North American Veterinary Regenerative Medicine Association. She's the immediate past chair of the preclinical models section of the Orthopedic Research Society and a past chair of the ACVS Board of Regents. Whew. And in her spare time, apparently she has some, she rides horses and is an avid backcountry skier and mountain biker and whitewater kayaker. Dr. Brad Nelson, also a good friend, is an assistant professor of equine surgery at the Johnson Family Equine Hospital here at Colorado State University, specializing in minimally invasive orthopedic surgery. Along with his clinical appointment, he is a principal investigator within both the Orthopedic Research Center and the Preclinical Surgical Research Laboratories, both here at the C. Wayne McElraith Translational Medicine Institute. He completed his DVM at the University of Wisconsin-Madison, followed by an equine internship focused on surgery and imaging at Washington State University. In 2010, he came to Colorado State University for a residency in equine surgery and became board certified by the American College of Veterinary Surgeons in 2014. Following his residency, he completed a PhD in translational orthopedics and articular cartilage imaging through the Orthopedic Research Center, and he is an ACVS Fellow candidate in minimally invasive surgery. So as you can see, we've got some incredibly talented and accomplished instructors for you this evening. Without any further delay, I think I'll turn the session over to you, Dr. Goodrich.
All right. Thanks, Dr. Palmer. Really appreciate the introduction. And so welcome, everyone. As Dr. Palmer said, we titled this session, How to Shorten Your Equine Arthroscopy Learning Curve, Tips and Tricks. And really we're going to be very basic in this webinar, and it's really for the new learners. And this is something that you could potentially view this again prior to any of our equine arthroscopy courses that we'll be having. We have a basic and advanced arthroscopy course that's set for August, and then another one that is set for September that is going to be focusing on intra-articular fracture repair. So we have a lot of exciting things coming up for arthroscopy, a lot of exciting courses. And this is, again, for the new learner, but just some things that, Dr. Nelson and I have been teaching arthroscopy now for quite some time, and just little tips and tricks as you are starting to learn this skill that we think if you focus on in the beginning, it will make your learning trajectory hopefully shorter. So this is available for viewing, as Dr. Palmer mentioned, as we go along. So we'll go to the next slide. Thanks, Dr. Nelson. Before we start, we just obviously want to pay homage to Dr. McElraith, because he started equine arthroscopy in horses many years ago. So started learning the technique from human surgeons in 1975, developed those through the years. And this, I love this picture because this is kind of how it started. I couldn't imagine doing arthroscopy this way. But that's where it started in the 70s. And again, he learned it from the human surgeons and brought it to equine. So there are some wonderful books along the way that have been published, with the most recent being the 4th edition. And you can see that on the slide on your right. So these are sort of the Bible, if you will, for equine arthroscopy. So have this in your armamentarium of books when you're learning arthroscopy, because they're very helpful. Okay, we'll go to the next slide. And so what Dr. Nelson and I are going to point out, these are sort of the 7 basic things that I think are important to remember as you're going forward in equine arthroscopy when you're learning. So anatomy, leg positioning, the access that you can get to in the joint, efficient equipment use, the portal creation once you initially get your scope into the joint, then creating portals appropriately and that is extremely important. Fluid pressure systems and control of your fluid pressure, and then proper instrument handling. So these are just some very basic principles that if you can think about this going into learning arthroscopy, then you'll be ahead of the game and again, shorten your curve. So next slide. Okay, so I'm going to talk about the first 3 things on the slide we just spoke about. And I know this is very basic, but a really important concept. Know your anatomy. So know the limb, the joint that you're working on. Have an anatomic specimen next to you while you're learning. That can be extremely helpful because you can look at your joint and look at the bones and really get a feel when you're learning. And I still do this sometimes for various fracture repairs as well. Some of the more difficult arthroscopies, it's really great to do this. So have that in the OR or have that in the dissection room when you're learning arthroscopy, and it'll really make your learning curve shorter. Know where your soft tissues are positioned and how to avoid them, right? And we're going to have I'm going to have a couple of videos in a few slides that show you this, but you can see a freeze-dried specimen here, bones and freeze-dried specimens here in these pictures. And having this available, again, will allow you to go back and forth between your cadaver and then your dissected bones. And potentially, if you have a freeze-dried specimens near you, it can really give you a concept of, the different layers you're going through to get into the joint with your arthroscope. Okay, next slide. Positioning. Most horses, most of the time we perform arthroscopy with the horse in dorsal recumbency. There are some things like tenon sheaths, certain arthroscopic procedures that we do in lateral, but for the most part, our joints are positioned in dorsal. The horses are in dorsal recumbency. So when you are learning arthroscopy, really important to position the limb, as you can see here. And again, we have a video, we have some videos that we're going to demonstrate this, but position the limb on the screen as the leg is positioned on the table. And Dr. Nelson is going to go through how to ensure that what you see on the screen is how your leg is positioned, because again, that will allow you to manipulate your camera without being confused or upside down, etc. Think about how to position the joint to give maximal distension. So you have to temper that with maximal distension, but also having access to the things that you want to see arthroscopically. Again, we have videos to demonstrate that. Next slide. And then the final thing that I'm just going to touch on is access. And so again, think about when your leg is positioned, what you're trying to see. So for instance, in a fetlock joint, and again, we'll show this, but in a fetlock joint, when you're looking at the dorsal aspect of the fetlock joint, you're going to want the limb in extension. If you are performing arthroscopy on the palmar or plantar aspect of the fetlock joint, you're going to want that joint in flexion. So really basic things that are hopefully very logical to you, but really, thinking about those really basic principles. And then I want to just point out in the diagnostic and surgical arthroscopy book, every joint is elaborated in there in terms of where your arthroscope is positioned, where your instrument comes in, and what you can access there. So use this book appropriately, have it in your dissection room. And when you're learning arthroscopy, it's very, very helpful as a reference to show you exactly what you can access and have a concept of that going into any joint that you perform arthroscopy on, and that'll really help you, again, shorten your curve. So the next two slides are just some basic videos of positioning, access, and describing the very beginning. I'm not going to show you in these videos. Dr. Nelson will show you the arthroscopic matchup, but again, just very basic consideration of positioning, etc. So you can go ahead and.
So this will show a video of the basics of doing arthroscopy on a fetlock joint. And the first thing you want to start out with is thinking about your anatomy and your joint. So we'll demonstrate doing arthroscopy on the dorsal aspect of the fetlock joint. So you would want the positioning so that your fetlock is in extension. If it's in flexion, you'll have a much tighter joint and much less room to move around. So that's where you would like to think about to start with your positioning of your limb and what is going to give you the highest amount of capacity to view the joint. So in this case, for the dorsal fetlock, it would be in extension. A helpful thing also is to have a joint, potentially a bone, that's right next to you when you're first learning, and think about the areas of the fetlock that you can see. And you can also refer back to the anatomy when you are scoping the joint. So you can see here, this is about what we'll see in the dorsal aspect of the fetlock. Obviously, if we flex the joint, we'll be able to see a little more of the joint. However, that will make the joint space much tighter. So think about that. The other thing that you'd like to think about is this is a freeze-dried specimen, and you want to think about your anatomy of where you'll be going through with your incisions as well. So this is showing the extensor tendon coming down and where that is on your cadaver. So think about what soft tissues you want to avoid. Sometimes you can't avoid them, but if you can, you'd like to go on either side of the extensor tendon when you're performing arthroscopy on this area of the joint. Okay, so now we'll start with first distending the joint. We'll put a needle into the back of the fetlock because that's the area that we like to aspirate as well as obtain fluid, and it's a nice landmark just in between the back of the cannon bone, the back of the condyle, and the front of the sesamoid bone. So you can see just 10 to 15 mils of fluid will distend the joint nicely, and that will give you plenty of space. We'll distend it extra for these purposes. And that will give you a nice distension of the joint. And that obviously is going to make it a little safer when you make an incision through your joint capsule. Next, we'll go ahead and make an incision. And what we like to do in the Fetlock, and again, these are just little rules of thumb that will help you when you're learning arthroscopy. In the Fetlock, the dorsal aspect of Fetlock, we like to divide it into 4 quarters, okay? And by doing that, that kind of helps you know where you're making your incision. So for instance, a dorsal P1, we would go into the top lateral for a medial dorsal P1 fragment. We would go into the top of the lateral quarter to get a good view with, again, the Fetlock in extension to best see your proximal P1. When you go to make your incision, you also want to make sure you make a big enough incision for your obturator and sheath to go through, but a small enough incision so that you do not have back leakage of your fluids through your incision. So we'll go ahead and make an incision through the joint to the skin, then through the joint capsule with a little bit of an angle. And that's, of course, the angle that you would go through to get into the joint. Okay, and we have a blunt trocar. Okay, and so you can see then getting into the dorsal capsule nicely. At this point, our fluids are shut off because we have nice distension. And this is where you want to think about where your light source is. Remember that your light source is always on the opposite side of your view. So this is where your light source is coming in, and your lens will be looking away from that. So you'll be looking 180 degrees from your light source. So here is your light source. So you will be viewing 180 degrees from where your light source is coming in. So now you want to ensure that you're looking in the right area of your Fetlock, that your light source is in the correct positioning.
Okay, great. And we'll go and just demonstrate the same on the Carpus.
So this leg is in a position for demonstration of arthroscopy of the middle carpal and radial carpal joints. The leg is in better position here for visualizing the middle carpal joint due to the necessity of having the joint open and flexed to access all the bones of interest. So this bone specimen right next to it shows the location of where those bones are, and when flexed, this middle carpal joint will open much more so we can see the articular surfaces of the bones here. For the radial carpal joint or antebrachial carpal joint, flexion does not need to be as extreme, and the leg can be extended a little more. However, it's extremely critical for the middle carpal joint that you have a large degree of flexion, or you will have difficulty putting your instruments into the joint without scathing around the cartilage and causing iatrogenic trauma. So this limb is positioned for middle carpal arthroscopy, and it's important to recognize the location of the anatomical structures of interest and the soft tissue structures that you want to avoid in making your instrument and arthroscopic portals. So this skeletonized view shows us where the bones are, and you can identify where the carpal metacarpal joint is in relation to the middle carpal joint and where your portals should be to accommodate examination of the joint. In a soft tissue model, you can see where the extensor carpi radialis tendon is in place, and that's a structure we want to make sure we avoid in putting our instrument and arthroscopic portals. And there is a sheath surrounding that extensor carpi radialis tendon, and so going into that structure can complicate visualization within the middle carpal joint, but then also can leave the horse with secondary effusion in that carpal sheath, which is an undesirable outcome. So recognizing where those soft tissue landmarks are will help you identify where to make your incisions in examining the joint. So to distend the middle carpal joint, first you want to identify either side of the extensor carpi radialis tendon. There's a depression for where your fingers actually fall next to that, so you can identify where you're going to make your incision first. The carpus is an exception to most other joints that we do arthroscopy on, in that we create a skin incision before we distend the joint. And that's done to help avoid going into the extensor carpi radialis sheath or the extensor carpi radialis tendon. So here, when you feel the depression in the middle carpal joint on either side, you make a skin incision with your number 11 blade to just separate through the skin. As opposed to other joints where you make arthroscopic portals, you use a needle to identify where you're going. In the carpus, the portals are pretty much exclusively in the same location, so that also doesn't cause concern. After the skin incision is made, a needle is advanced deep into the joint and distended with saline or fluids. And here you can see the middle carpal joint is distending as fluid is being put into the joint. It usually takes somewhere between 10 to 20 mils, depending on the case. And this is a little bit more distended than we would necessarily need to do in a clinical case. But for the sake of demonstration purposes, you can see the bulging of the capsule. Once the joint is distended, then you can go back in with your 11 blade. You want to make a stab incision, but make sure that your portal and your hole in through the joint capsule is a little smaller than through the skin. So you make a stabbing motion, trying to avoid articular cartilage based on your knowledge of anatomy, and then slightly extending the duration of, or the length of the carpal incision so that you can facilitate placement of the arthroscopic cannula with obturator. We use a blunt obturator, and we advance through the incision across into the joint, trying to avoid contact of the articular cartilage. Some older camera systems will have a sharp trocar. We want to avoid those sharp instruments because it's very easy to scathe and cause trauma to the articular cartilage. So the blunt obturator really helps protect us from that situation.
Okay,
so this leg is in a position.
That's sort of the basics, and then Dr. Nelson's going to take it from here on instrumentation and portal creation, etc. Are there any questions at this point?
I don't have any in the chat. I've got a few questions for you that I might hold till the very end. I guess one comment, semi-question, is pointing out, obviously, what you were doing there was a demo and a cadaver because there wasn't full-on, gowning, etc. Probably worth emphasizing that. Would you agree?
Yes. Okay,
wonderful. And then I'm sure that our audience appreciates the fact that you are really emphasizing the basic principles. I just think so often we assume those, we gloss right across them, and that can make the learning curve that much more difficult. So again, a huge thank you for kind of pointing out and emphasizing those important principles. And the last thing I guess I was excited to see was your reference to Wayne back in the day looking through the arthroscope, and that reminds me, in my introductory remarks, I talked about this collision between inspired learners, engaged educators, and meaningful experiences. And, as you know, we always talk about really that sort of collision is the heritage, actually, that helped Wayne to create and to become the father of veterinary arthroscopy. He was the inspired learner. Fortunately, he had in Lanny Johnson an engaged educator, and there was meaningful experiences, and look what has flowed out of that. So it really is quite incredible.
Thanks, Dr. Palmer. And I like to call him the Godfather, actually.
Yeah, I think so. Great point. Well, again, thank you for great information, Dr. Goodrich. And I'll now welcome Dr. Nelson to the stage, who can continue on sharing some of these valuable tips and tricks.
All right, great. So yeah, we'll kind of follow on with the outline list of tips, and some of this you'll see we kind of reinforced across both arms of this presentation. But I think that, as Dr. Palmer and Goodrich mentioned, that's kind of the core that sometimes we glaze over as educators. Sometimes the basics kind of lose traction for the more exciting parts, but teaching enough students and residents over the years, you recognize that if we had spent a little time in the beginning emphasizing some of these principles, sometimes that actually speeds up your learning process in the long haul. So moving on to a little bit from anatomy and positioning, we're going to talk about efficient equipment use. And so a couple components within that that are helpful for the new learner. And so the first thing to think about is, how does the camera work? And so it's really important to keep that camera and how it functions at the forefront of your mind as you're scoping multiple joints. As veterinary surgeons, we don't have the luxury of doing a single joint like some human surgeons do. So sometimes we have to put ourselves in different positions and deal with the restrictions that we have of patient positioning. So one of those concepts is knowing how the camera works, and seeing in this picture on the left, trying to have that camera in a consistent orientation. And so if we look at the camera, there's the buttons on the top. So in that left image, if we have that towards the top of the screen or away from gravity, and we have the camera cord at the bottom, as one of my mentors used to say, always keep your feet on the ground. And that way, if that camera stays in that position, you can really use your light cable and other knowledge of anatomy and not have a third layer of complexity in orientating yourself. So as shown on the right, you can see if you twist the camera, it doesn't necessarily matter which position you have it in, but just avoid twisting the camera back and forth. That ultimately will get you confused, and it'll be really challenging to keep your head straight on what's up and what's down. Along those same lines are how the arthroscope camera itself works. So the one that we use in equine surgery predominantly is a 30-degree view. And so that means if we have that camera facing upwards, as shown in the left here with the buttons on the top and that cord towards the bottom, we're going to show the view more below, so at the bottom of the image. And as Dr. Goodrich mentioned, if we're having a hard time thinking of how that works, imagine yourself looking through the light cable. If we look through the light cable on the top and we look down, we can see what we're going to see is at the bottom of that camera. Now, if we just move that light cable 180 degrees, but don't move that camera position, we're going to do the opposite. So that camera is at the bottom, and as we look through it, we're going to look up at the other source of the joint. So recognizing that we have a 30-degree view and using that light cable while keeping that camera in a fixed position is really going to help us be efficient in our maneuvers. Another thing, as equine surgeons, we put ourselves in a lot of complicated positions. And so keeping in mind what is going to make the procedure the easiest, but also not make you sore at the end, is going to be the best for you in the long haul. And so usually you want to have that camera system and that monitor facing in a position where you're scoping the joint comfortably, but then just looking forward and seeing the inside of what's shown on the camera, as shown in this image on the left. Now, this image on the right is a view that they turn the screen away for the sake of the picture, but it does emphasize the point that if you're doing arthroscopy in this position and you're kinking your head off to the side, if you have a longer procedure, that's ultimately going to be really hard for you to maintain, especially if you have multiple surgeries within a day. So keep in mind the positioning and what's going to keep you the most comfortable for doing as much surgery as you need to accomplish. Now, going back to portal creation, we talked a little bit about this in the beginning section of this webinar. We exclusively use a number 11 blade, and that stab incision lets us make a nice direct cut through the skin, subcutaneous tissue, and the joint capsule. There are some exceptions to how we make these incisions, but by far and large, that's how we make all of our cannula incisions and portal incisions, except for, as we talked about in that video, for the carpus, because of avoiding that extensor carpi radialis tendon. And then also where the joint capsule is very deep, we aren't going to make really deep stab incisions with the blade. We'll rely on the obturator to kind of advance through the joint capsule in those cases. But for the sake of this lab, for the introductory learner, keeping in mind that we want to just have a stab motion rather than repeated stabbing motions is going to be the most helpful. And then we want to make sure that we don't make our incisions too big. I know that's a hard, nebulous way to describe an incision, but we don't want an incision so large that once we start putting fluid into the joint, it all pours out and we don't get any pressure. So it's this fine balance about making the portal big enough, but not too big so that you just don't get any distension. By far and large, this usually means that we get the tip of the 11 blade in, and because it's a taper blade that gets wider towards the handle, we can usually make a pretty efficient incision with just a single stab with a slight extension. Now, how we create this portal is pretty important. Like I said, luckily the 11 blade that we use does most of this work for us. But if we look at this diagram on the right and we look at where the skin is, where you're going to start passing your blade through the subcutaneous tissue and into the joint, we want to have some sort of a trapezoidal orientation to that incision. And what I mean by that is we want a smaller opening into the joint capsule than we do in the skin. And that's so that we can, as we pressurize the joint with fluids, those fluids find their way out without building up and causing a lot of extravasation underneath the skin. In these same lines, we want to be sure to make a single focus strike with that scalpel blade. Some people tend to, when they're first getting out, do multiple stabs. And if you happen to make multiple cuts in the joint capsule, but a single cut in the skin, you can ultimately cause a lot of extravasation and make it a lot harder for you to manage. And so if we do this effectively, fluid comes out through the skin portal, and that's the best way to go. So I'm going to show you what happens if we do this ineffectively and what the effect of extravasation can have on you. And so if we do the opposite of what's shown in the top center of this screen, where we have a smaller skin incision but a larger joint capsular incision, we have what's shown on the right here, where as you build fluid pressure within the joint, it builds out through the joint capsule into the subcu space, but it has a hard time exiting the skin. And so because of that, the subcu space expands, gets very edematous, and the effects of that are that we have a harder time finding that singular portal to put our instrument through. And then we also actually have a collapse of the joint because that subcu space fills with fluid and puts pressure of that capsule towards the joint. So it makes it harder on multiple fronts for us to deal with that. So if you make your portal incisions effectively and keep those things in mind, you're going to have a better time to focus on anatomy and what procedures you need to accomplish within the joint. So building up fluid pressure causes joint collapse. So fluid pressure systems, you'll see these are different depending on which system you have in your clinic. If you come to the arthroscopy course, we use a lot of Arthrex equipment. And so the one at the top here is the fluid delivery system that we have available. The nice thing about those systems are that they're pressure controlled. So they're set that they'll sense the pressure in the joint that's building, and they'll slow down or speed up accordingly, depending on how much fluid you have in that joint. More economical pumps like the Cole-Palmer one shown in the lower right don't have that fluid pressure sensing. And so you have to have somebody that's non-sterile turn on and off the system when you get too much pressure and when you need more. So pros and cons to both, but just realizing what system you have and knowing how those fluid systems work are going to be helpful in being efficient with how you learn arthroscopy. How much pressure we need to fill into the joint to do what we need to do will really depend on the joint of interest. And so lower limb, so distal limb arthroscopy, generally we need lower pressure. Those joints have a larger joint volume. And so once they build up with pressure, we don't need a large high pressure to extend or distend those structures. The exception to that would be the stifle, so particularly the femorpatellar joint and femorotibial joints. There, the joint volumes are much higher. And so we have to generate a lot higher pressure to maneuver and accomplish what we need to from a diagnostic and a surgical perspective. And one of the other things that's really tempting when you get into the joint, especially as you're learning, you get excited, you want to make your instrument portal, but I would caution you to just make sure that the joint distends and you get nice pressure of that joint before you make your instrument portal. If that joint is distended, that capsule is going to push away as far as possible, and it's going to help you create that portal incision more effectively. So learning how you maneuver your fluid pressure systems, and then also taking a breath once you get in and doing your exam before you create an instrument portal and have leakage is going to help you in the long haul to be efficient. And so looking for how much pressure is too much pressure, that's a hard global statement to make. However, if we look here in the picture, we can see that there's quite a bit of fluid squirting out through the incision. And so here the pressure is probably a little bit high for what we need for this particular purpose. And if you use the Arthrex system, pressure of 60 is pretty adequate for most of our distal limb surgeries. But however, even though there's not a hard fast rule here, We have to rely on our knowledge of, are we building extravasation? Are we squirting across the room too much? And we're going to have to adjust those need be. And so that's something that we're going to have to pay attention to as we're doing our exam. Instrument handling is our last little topic to pay attention to. It's important to make sure as you use your instruments in that instrument portal that you hold it for stability and controlled movement, especially when you're using curettes, which is one of the workforces of us in equine arthroscopy. If you hold it just by the handle here and you don't put any traction against the curette, you don't really have an effective way to maneuver. We'll show this in an upcoming video, but if you hold the instrument better, like as shown on the images on the left and the center, you're going to have a lot more efficiency in using that instrument. So this video is going to take off a little bit for where Dr. Goodrich has ended, and we're going to look, we're going to see the external view on the left, and we're going to have an arthroscopic view on the right that'll hopefully reinforce some of these principles.
In the joint here, we're going to pay close attention to how the camera is positioned. The most standard way is to make sure that the light cable is, the camera cable is facing towards the bottom of the screen. What you don't want to do is have to twist the camera as well as the light source. That gives you two angles to try to correct. So if you keep the camera in a singular position as shown here with the buttons facing up and the cord facing back, then all you have to do to change your orientation is move the light cable. If you twist this, that gives you two planes of visualization that makes it challenging for your brain to comprehend. So keeping the camera in an upright position will keep it straightforward in your head. Then you can use the light cable to orientate around the joint. It's important as you're using that light cable to remember that you're looking through the light cable to the opposite surface. In the picture here, right now with the camera, the light's course coming from the top, we're looking proximally, and with it down in this position, we're looking distally, which is at the top of the screen in this video. If we go 90 degrees in between, where the light camera is looking right towards the leg, we're going to get the most direct on view towards the articular surface. So without doing a lot of twisting of the camera, certainly there's back and forth motion to see different parts of the joint, and the light cable is used to look at different surfaces, but there's no twisting of the camera during this process. And in the Carpus, so with the Fetlock, we would do a needle before we make an incision, but here, as we mentioned earlier, we're making an incision first, and then but we still need to make a hole into the joint capsule. So here, if we just extend that, we make a smaller hole into the joint capsule, and then we advance an instrument, whether that be a right-angled probe or an egress to clear out the joint of blood and initial debris. And then using the probe, examination of the palpation of the surfaces can be performed. If the incision was made too large in the joint capsule and it was larger than the skin, you would see a lot of extravasation, and there's a lot of difficulty in having an instrument be able to go in through that portal. Additionally, it makes it much more challenging once you get subcutaneous extravasation. It's much more difficult to visualize the articular surface because you start collapsing the joint capsule based on that buildup of fluid outside of the joint capsule. How much fluids we need to make sure we have sufficient distension is important. In the limbs here, so the carpal joint, the distension is at a lower pressure than you would experience for a stifle. So the femoropatellar joint, for example, requires a lot more fluid and higher distension in some cases to elevate off structures so that you can do a full examination of the joint. However, in the distal limb or up into the carpus or tarsus, this fluid rate is much smaller. If you're noticing a lot of fluids egressing out of your portals, or you're noticing a lot of extravasation, your pressure may be too high. So keeping an eye on those situations as you're doing your diagnostic exam will help make sure that you can accomplish your surgical procedure as efficiently as possible. It's also important to make sure that you ergonomically hold your instruments effectively. And so it's very tempting to hold the instrument just by the handle and having a long part of the instrument not be in contact with the joint. However, especially when you're using a curette, it's important to make sure you get the leverage you need by having your finger against the curette. So for example, here, if we just grab the handle, we don't have an ability to put a lot of traction on the joint, and we wouldn't be very efficient in our strokes for debridement of articular cartilage. However, if we put our hand as shown here, we can have a lot of leverage pushing on that surface, and we're much more efficient in being able to control how that curette functions.
All right, and so I won't belabor it, I think, because we reintroduced it many times, but here's just another list of some of those important things that if you're just starting out with arthroscopy, spend a little bit of extra time thinking about those things, and that will really help you really speed up your efficiency in learning arthroscopy. And so with that, I guess if there are any questions on that or any residual ones from Dr. Goodrich, I think that's all I have.
Yeah, a couple of questions here. And again, can be you or Dr. Goodrich answering, or maybe we don't even have the same answer, and that's okay too. But just on average, how long does it take the average learner to start to get comfortable with arthroscopy for common equine joints like the Fetlock and the Carpus?
Yeah, I would just say that that's a very individualized thing. And we see, in terms of thinking of residents, some residents just, get it faster than others. But that in the end, I have to say, that doesn't mean that if you comprehend more quickly, that, it's that much better in the end, a better arthroscopist. I think it's just sometimes it takes some people more practice to get to the same point, but ultimately, practice makes perfect. So I will just, speak to that in terms of the learner and how long it takes. Like, don't get discouraged if you're not getting it, because again, the more you practice, the better you will get. And but on average, I would say for somebody to feel comfortable in a fetlock and a carpal joint, let's say what we just kind of went over, maybe 10 to 20 times of performing arthroscopy on that joint, where you're really like feeling like you're comfortable, and the anatomy, and you can proceed in a reasonable period of time. And Brad, you may have a different impression on that, but
no, I think it's pretty much the same from my perspective. I will say, not to reinforce what we just talked about, but I do think some of the residents that even down the road that don't remember these principles that we talked about, I think sometimes you see them struggle a little bit. So I think, it is very individual dependent. And I think sometimes I'm probably not the best about reinforcing some of these, core concepts at the start. And I think that actually would increases everyone's efficiency. But yeah, I would agree. 10 to 20-ish times. And, sometimes in the second year of their residency, I'd say most of them feel like they're relatively comfortable for these entry-level joints, I guess, if you want to call them that.
I love that you pointed out that some people are naturally a little bit more adept initially, but that doesn't necessarily translate into them becoming a better arthroscopist in the long term. What were the lyrics? Pinball Wizard, there's got to be a twist, something to that effect. One of the things I've seen in your courses is, everybody's on their own learning curve, but the transformation that I see from the early laboratories to the late laboratories is phenomenal. So regardless of what one's natural skill set is or inherent sort of comfort, it's kind of across the board. There's this amazing growth that takes place in that curve or in those courses. And for me, looking in from the outside, that's always fun to watch. Another question here is, how do I deal with the loss of visibility? So whether it's a hemorrhage, hemorrhagic joint, you get fibrin accumulation with sepsis, etc. Any tricks on clearing up that view?
go ahead,
Yeah,
Brad.
you want me to go? So pressure actually helps a lot in that case. So you can increase the pressure and you can get some benefit with that. I will say if your portal's too big and you increase the pressure, that's going to be a constant battle. So I think it reinforces making sure you have good portals. And if you do have hemorrhage, increase in the fluid pressure. I've been at places where we've done chilled fluids. So having a bag of saline in the fridge or even in the freezer enough so that it's cold, you can sometimes get some benefit there. And I don't know if I've ever done this in my time as I've gotten older, but I've seen other surgeons put a little bit of epinephrine in their fluids as well for some light hemorrhage. But honestly, I think the pressure and patience are probably the two most important. It's tempting once you get in there and you turn up the fluids that you still maneuver around. And sometimes just pausing, counting to 10, letting that pressure build up gets you a lot of what you need. I don't know, Lori, do you have anything?
Yeah, no, agree with all that. And then, just some other things if we perform tenoscopy, I usually do that with a tourniquet. I use tourniquets less and less anymore, but that is an area that will help with hemorrhage control. Thinking about, in the tibiotarsal joint specifically, trying to not go crazy with doing a synovectomy, because there are certain joints where doing too much resection of the synovium will really, result in hemorrhage, and it can make your arthroscopy go much longer. So trying to consider that. I mean, obviously, with some things you have to perform a synovectomy, but thinking about not too aggressive resecting to minimize the hemorrhage that will ensue after that.
All right. Any last minute pieces of wisdom for the budding arthroscopist from either of you?
Practice makes perfect. I always tell my residents the best arthroscopists that are at the end of their residencies are the ones that get in there and just, make mistakes on cadavers, or, continue to practice and make chips in the joint and utilize your instrumentation to curette, and just really, when you're learning in a situation where you're not under pressure and your senior surgeon or your client or whoever is there in the room is putting pressure on you, right? Like, that's the best thing to do when you're by yourself and least amount of pressure on you, but really kind of working on your technique. So it's definitely one of those procedures where you need to put the time in and it will pay off.
Brad?
Yeah, she took mine. That's probably the best one that I can say, but also, especially as you're learning out, that arthroscopy book is fantastic about what you can see. And if before you go into it or as you're practicing, you know what you're supposed to be able to access and what you're supposed to be able to find, that's half the battle. People, young trainees that I see put the scope in and then try to find things that you actually can't see very well. I think doing a little bit of that homework up front and practicing really is gonna help you out, particularly in those cases where you've got a bunch of fibrin in the joint and you can't see anything normally anyway. And so then you do have to rely on your knowledge and some of your muscle memory for how to go in there. And so those are tough cases, but doing some of that homework up front or knowing what you're supposed to be able to see is going to help you immensely in the long haul.
So what I'm hearing from both of you is it is a pathway. It's not an instantaneous skill. You start by sticking to the principles that you guys have discussed, and then it's lots of hands-on. And that then as you walk down that pathway, then things start to click more and more and more. And next thing you know, you're sitting there in front of the camera talking about how to do this. So Yeah, great information. I want to thank both of you for wonderful presentations this evening. I think really, really practical, really, really helpful for our audience. And I just appreciate your willingness to contribute to this CE Elevated webinar series. Special thanks as well to Arthrex Vet Systems as our sponsor for this webinar episode. Doctors Goodrich and Nelson will be joining other doctors that you may have heard of, Doctors McElwraith, Kowcheck, Ian Wright, Alan Nixon, and others for 2 hands-on equine arthroscopy courses, both a basic and an advanced course here at CSU in August. And as you mentioned, Dr. Goodrich, we also have a great faculty lineup for an Arthrex-sponsored AO course on equine intra-articular fracture repair in September. So all of those courses are very popular training courses. It's a gorgeous time to be here in Colorado. So if you're interested in those, don't delay registering for them because those are very popular courses. Check those and other early bird registration discounts out at csuvetce.com.